السلام عليكم. جزيل شكري الأخ الفاضل الأستاذ دكتور جمال سامي على دعوتي إن أنا أبقى مع حضراتكم النهاردة. الموضوع اللي احنا هنتكلم فيه النهاردة هو Constipation in Pediatrics Facts and Math. خليني أقول الحقيقة إن مفيش أي conflict of interest مع أي حد خالص النهاردة من الشركات. It's a pure scientific talk. Medical definitions of constipation vary from most parents' definitions between infrequent defecation إلى painful defecation or both. Parents are usually worried that their child's stool are too large, too hard, not frequent enough, and or painful to pass. الحقيقة لو الأم دي جت complaining of constipation, by inquiring, it was clear that the infant passes a small loose motion every 18 to 30 hours. Significant straining during defecation and colic is between. يا ترى في الكونتكست ده هنقدر نقول this is constipation? Do you think it is yes or no? طيب ما تيجي نشوف الديفينيشن كده هيحصل ايه. A delay or difficulty in defecation present for 2 weeks or more and sufficient to cause significant distress to the patient is the next begin definition. There is consensus on childhood constipation terminology in a period of 8 weeks with at least 2 of the following symptoms: defecation less than 3 times per week, fecal incontinence greater than once per week, passage of large stool that clog the toilet, palpable abdominal or rectal fecal mass, stool withholding behavior, or painful defecation. لو لقينا 2 من الحاجات ديت وبقالنا أكتر من 8 أسابيع, according to the PACCT, it is constipation. Do you think the most important item in defining recent constipation in children would be the delay, the consistency, the volume, or duration of defecation act? Actually, it is the delay. In recent cases, within few months, usually we speak about delay. However, if it is long-lasting constipation, usually the consistency is the most important item in the definition. So hard stool is usually considered in this context. However, if this is the definition of constipation, when can we say this is a functional constipation? According to Rome 4 classification, for infants, toddlers, 2 or fewer defecations per week, at least 1 episode per week of incontinence, after acquisition of toilet training, excessive stool retention, painful or hard bowel movements, large fecal mass in the rectum, large diameter stool which may obstruct the toilet. لو لقيت 2 من دول أكتر من شهر في infants up to the age of 4 years, now we can call it functional constipation. وخد بال حضرتك, it can be associated with irritability, decreased appetite, and or early satiety. Accompanying symptoms disappear immediately after passing a large volume of stool. One of the myths here is that mother will say, stool is not hard, it's not constipation. Actually, a fermentative diarrhea can occur on top of constipation period, and here the stool coming, whether incontinence or not, may appear diarrheal, and the mother will tell you this is not. One of my clinical tips here is when constipation is followed by a period of diarrhea, ask about the odor of the stool. If it is very offensive, this is fermentative overflow diarrhea. If it is not, this is an alternating bowel habit, and think on the causes of alternating bowel habits. Another myth here is that mothers will say that he is doing every day, so this is not constipation. And actually, if he cannot empty the rectum, he may be having very small amount of stool on daily basis. However, rectum is loaded and there is difficulty in passing the stool, with or without incontinence. You can diagnose this case as constipation. Take care here. Sometimes we need to have a plain x-ray of the abdomen and pelvis to show the impaction of a stool and loaded colon, to convince some of the very educated patients, especially when they are sons or daughters of doctors. Regarding the epidemiology, whether it is 0.1, 0.5, 10, or 70%. What do you think? Actually, prevalence ranges different studies between 1% and 30%. And in Egyptian study, we found in unpublished data done in the 90s, it was a master thesis supervised by Professor May Nassar and myself, and we found that constipation was 17.4% in school children. And it was more in urban than in rural areas, and more in high social standards than in average and below average social standards. This study was done on almost 20,000 school children. Etiology may be functional, like infantile rectal confusion, and this is usually coming from an obsessive mother while she's having a toilet training for her infant. ازاي يعني حكايه الكونفيوجن؟ ما تعملش هنا، ما تعملش على السرير، ما تعملش على الكرسي، ما تعملش على الارض. هو فهم انه الكومن سنتنس بتوين الاوامر دي كلها ما تعملش، وبالتالي هو هيبطل يعمل لانه هو مش فاهم انه المكان هو اللي غلط وان المفروض يعمل في التويلت، فبالتالي بيبدا الطفل ما يفهمش ده غلط، ويبقى الاوردر بالنسبه له ما تعملش ما تعملش ما تعملش فكر. ممكن تبقى idiopathic functional constipation، وممكن تبقى functional fecal retention، وممكن تبقى irritable bowel syndrome constipation type. كل ده اسمه functional يا جماعه. ممكن يبقى neurologic. مثال Hirschsprung disease as a congenital form of constipation in which there is abnormal with the ganglia content of the colonic mucosa and rectal mucosa. If the number of mucosal ganglia is normal but it is abnormal in function and shape, this is one example, which is neuronal intestinal dysplasia. Chagas disease in acquired form of this pathology. Familial dysautonomia can cause same condition, spinal cord dysplasias, and botulism. Pseudo-obstruction may be a primary pathology of the nerves or secondary to other causes of pseudo-obstruction. On top in Egypt is the Epstein-Barr virus and cytomegaloviral infection. Obstructive pathology may be due to abnormal anteriorly ectopic anus, may be due to anal ring stenosis, may be small left colon like in infant of diabetic mothers, meconium ileus equivalent strictures after surgery, or tumors or masses. Endocrine and metabolic causes are not uncommon in clinical practice with diabetes mellitus or diabetes insipidus, hypothyroidism, pheochromocytoma, porphyria, hypercalcemia, especially when the abuse of vitamin D in large doses may be secondly affected into hypercalcemia and constipation, hypokalemia as well. In the immune disorders like scleroderma, systemic lupus erythematosus, amyloidosis, graft versus host disease, it may present with constipation. Drugs may cause constipation like laxative abuse, in which the duration is very long, and especially using a very lengthy periods of laxative, stimulant laxative. Diuretics for long period, tricyclic antidepressants, narcotics, aluminum antacids, calcium channel blockers, iron and lead poisoning, iron intake or lead poisoning. Cow milk allergy may be associated with constipation, especially in the intractable type. And according to Iacono et al., it was the first report of constipation with cow's milk allergy. And our team detected that the best time of tolerance in this regards is 1 year. Elimination. A 10-year-old male child presented with constipation for the past 4 years. He passes a motion every 4 days, like a very thick cylinder with streaks of blood. Irregular laxative use can help him partially. Can this case be Hirschsprung disease? Do you think this is a presentation of Hirschsprung disease? Actually, no, because the very early life was very smooth. Anal examination of this child may reveal severe pain, fissures, piles, full rectum, and actually it is all of the above. Doctor asked for the following investigations: serum electrolytes, rectal biopsy, colonoscopy, and allergy panel. What among these you consider appropriate? Let us go through first the pathophysiology. Whatever the cause of constipation is, we have this vicious circle of withholding, that we retain the stool, so it accumulates, and accumulation will lead to pain, and pain can lead to fear, and fear can lead to withholding. And every part of this quadrant can be the starting point. For example, pain may be following infection, allergy, child abuse, trauma, fissures, and actually constipation is a good example of disease leading to perpetuation of itself. That is, constipation will cause constipation. A good history, the starting point of the disease or passing the first motion after birth, onset and duration, is it painful or not? Is there bleeding or not? Is there fecal incontinence or not? Is there any painful condition? In young children, parents often confuse withholding of stool with pain or excessive straining. This may be not a withholding. So we should know what is the common withholding behaviors. Squatting position, crossing the legs or ankles, stiffening of the body, holding onto furniture or mother, flushing, sweating and crying, hiding during defecation. All these are actually a withholding behavior. And you should have this differentiation table between Hirschsprung and functional constipation, because functional is more common, as we have said, and actually males are more common in Hirschsprung disease. Age of onset, it's infancy and very early life. However, sometimes an ultra short segment may be starting to be diagnosed after many months of life. Soiling is not known in Hirschsprung disease. It is known in functional constipation. If you have a BR examination, if it's necessary, you'll find a small empty rectum in Hirschsprung disease. However, full loaded rectum may be seen with functional constipation. This distinction is a constant finding in Hirschsprung disease. Investigations may include barium series, systemic causes search, manometry, endoscopy and biopsies, and some others. This is transition between narrow rectum and wider area of the sigmoid. And here is a loaded rectum. You may have this difficography in which he will try to do while he is with barium to see the movement of the stool containing the barium itself. You may have a study to assess the colonic transit time to differentiate low transit and high transit types. Anorectal manometry and colonoscopy may be indicated in very rare occasions, and their help is not of a use except in very prolonged intractable forms of constipation. Anorectal may help us to diagnose some cases with recto-anorectal dyssynergia, in which we may need more than laxative therapy. And sometimes rectal hyposensation may be diagnosed in the anorectal manometry. Colonoscopy may help only in very severe forms of eosinophilic colitis. One of the myths here is that BR examination is said to be essential. Actually, no. Examining the anal region is important, but doing the BR is not indicated except if you suspected the case to be Hirschsprung disease. Barium should be routine. Actually, no. The help you can get here is only if you suspected Hirschsprung disease. Anorectal manometry is essential. Actually, not. It's only needed in almost 1% of the cases of constipation. Colonoscopy is routine. This is another myth. And actually, we don't have this investigation in our portfolio for examination of a constipation case. And this was the MD thesis of Professor Marwadi, when we found that colonoscopy did not help us to either diagnose or treat specifically. Complications may include surgical conditions like piles, fissures, prolapse, and medical complications will include malabsorption and allergic manifestations and UTI. And this is an example of prolapsed rectum on top of severe constipation. Treatment will include immediate evacuation, maintain regular emptying of the rectum through dietary row or drugs. Biofeedback or Botox injection may be needed in severe conditions. Psychotherapy may be needed in some conditions. Limited, very limited place for surgery, except in Hirschsprung disease and some conditions in which the colon lost its absolute functions. So the World Gastroenterology Organization said that we stop medications which cause constipation, start by bulk forming agents, osmotic laxatives, pelvic floor physiotherapy, contact laxatives, enemas, prokinetics, and we may use as well the stimulant laxatives. Colonic evacuation is important. Treatment of painful condition associated is essential. If there is anal fissure, sometimes we may need xylocaine ointment. Establishing regular bowel habits by making it a style of life. When affected child had passed bowel movements regularly for weeks or even months, sometimes it reaches 4 to 6 months, without apparent pain, fear, or excessive straining, we can think in gradual withdrawal of the laxative therapy. Dietary modifications with using of prune, pear, or apple may help, although randomized controlled trials have not been conducted to examine the effect of increasing the intake of fluids, non-absorbable carbohydrates, or fiber on childhood constipation. We recommend this, although it's not an evidence-based therapy. Cow milk avoidance, and actually we suspect cow's milk allergy when the constipation is intractable before going to the Botox injection. Medication summary will be in the form of stimulant laxative intermittent and osmotic laxatives continuous, especially the polyethylene glycol, mineral oil, magnesium hydroxide, and lactulose, and are all effective according to small-sized studies. The key in pharmacotherapy is to use a sufficient amount of laxative to produce the desired effect. For example, in lactulose, it is 3 mL per kilogram body weight per day, the maximum dosage schedule. The following factors may warrant a transfer: uncertain diagnosis, evidence of intra-abdominal catastrophe, acute abdominal pain associated, if there is fever with, if there is bleeding with the constipation, if there are chills, instability of vital signs, absence of bowel sounds, acute recent change in bowel habits, unsuccessful or inadequate treatment offered at the local facility. We are at the end. Constipation is a common pediatric problem. Take care. In Egypt, it is about 17% in school children. Both doctors and parents underestimate this problem. Try to define the cause, otherwise recurrence will be the rule. Evacuate the colon, then maintain the emptiness of the colon. Do not be afraid of the laxatives, especially the osmotic laxatives are very safe for a long time, and intermittent use or short-term use of stimulant laxatives are essential in pediatric constipation. Otherwise, recurrence will be the rule. Thank you.